Okay, awesome. Well, thanks everyone for joining us. This is our first Q&A webinar with Dr. Eric Balcavage and Dr. Kelly Halderman for the Thyroid Debacle book launch. So we're super excited to have you guys on here with us today, and hopefully you brought all of your great questions. And for anyone that's watching not live, you're watching a recording, we have a bunch of questions in advance too. So hopefully we'll get to the ones that you submitted. But I guess before we get started, we'll do a little bit of a short intro from Dr. Eric and Dr. Kelly. Just, I'm sure you guys are familiar with them, but just to give them a little background here. So Dr. Eric, do you want to let everyone know kind of your background, what you do, what you specialize in, obviously, and then a little bit about the book coming out this summer?
Yeah, sure. My name is Dr. Eric Balcavage. My original background is as a chiropractor. So I started, I don't know, 27 years ago in chiropractic, and then wasn't long into practice, and I got kind of pushed into functional medicine. So because a family member was having some thyroid issues, I had to go back to my blood chemistry and kind of dig into blood chemistry and try and figure out what was wrong with the family member. As I did that, and I started talking to my clients that I was taking care of chiropractically, I realized how, there's a lot of people with chronic thyroid problems who were still symptomatic, still on, even though they were taking medications, they didn't feel well. And then that's led into this deep dive over the last 25 years of trying to learn as much about body chemistry as possible. And now, even though I talk about thyroid physiology quite a bit, really my goal is to help people with chronic health issues regain their health by identifying the root cause of excessive cell stress, which ultimately causes somebody to develop tissue hypothyroidism, cellular hypothyroidism, glandular hypothyroidism, and a cascade of other tissue issues that Kelly and I refer to in the book as a multi-system adaptive disorder. So doing this for a number of years and always kind of writing a bunch of stuff down. At some point, I decided I was going to write a book about 10 years ago, and it's been a slow process. Writing a book is one thing, getting a book published is a whole different thing, and as Kelly can attest to as well. And so it was really a push by a friend of mine, Dr. Ben Lynch, to just do it and get it done. And then with the help of Kelly, she's helped kind of speed that process up a bit to get the book to where it is now. And now we're hoping for a early summer release of the book.
Awesome. Thanks for sharing. Dr. Kelly, you want to jump in here and let everyone know what you do and why you're excited for the book to come out?
Sure. So I am trained in traditional allopathic medicine as a family practice doctor. And when I was in my training, I was really excellent at prescribing a pill for every ill, right? But I knew kind of in the back of my mind that maybe all these prescription drugs I was doling out wasn't really getting to the root cause, but that's not what we do in medicine. That's not what we're trained to do. We're not trained to ask why. So it really honestly didn't really matter to me because I was getting patted on the back for doing a great job. That was until I came down with my own health crisis. And I was actually, practicing medicine, and it was very stressful, but I started to have all these very weird neurological symptoms out of nowhere. And I eventually got diagnosed with MS. And I was told by my allopathic colleagues to basically go home and be with your kids. Like a death sentence. And I was like, well, that's not going to work for me. And so the why, the root cause, the why mattered so much. My life depended on it. And so I had to go back and get a naturopathic medical degree to figure out how nutrition works. Because no, we don't, as medical doctors, get very much nutritional information at all. And I had to learn about detoxification, all these things. And that literally reversed my chronic illness. And I also got diagnosed with Hashimoto's, thyroiditis, along the way. My root cause, Lyme, mold. So I do a lot of things to stay healthy these days. But as I was learning about naturopathic medicine, I stumbled upon this genius of a doctor named Dr. Eric Balcavage, and I devoured everything. I mean, like maybe I was like #1 fan club like ever. So I got asked to speak at a conference in 2018, and Eric was going to be speaking at the conference too. And I am front row, and I'm like, I'm your biggest fan. I think he was a little scared of me, actually, but I resonated with everything, the way he thinks. I resonate with the way he thinks and everything that the conclusions that he draws, and how he doesn't have opinions. He looks at the science. He's literally like devours medical papers and journals and all day long. And this guy knows his stuff. And so I'm honored to be a part of this book. I bring in the allopathic perspective because I want our readers to understand why your doctor does what he does or she does, because that's the rule book, that's the playbook. There's nothing wrong with what they're doing based on their training. Is it antiquated? Is it outdated? Is it not working? I would say yes, all of the above. But again, I'm just proud to be on this book to help bring that allopathic perspective. And I'm excited for you guys to get this book in your hands. It will change your life.
Let me jump in there for a little bit, because Kelly does a lot of pumping out, but Kelly's extremely bright person. I think that's one of the reasons we hit it off. We kind of both think about it from a very mechanistic standpoint, how things work, not just do a Band-Aid approach. And I think it's key when we talk about what's going on. I mean, we both came from from the medical model, and now we're in the functional medicine model. And I think we both had our periods of time where we were both kind of angry with medicine, allopathic medicine. And even the early part of the Thyroid Debacle book was very, I think, more of an angry writing of the book, because we were both still, in that kind of, why would you do things like that? Just like a lot of our clients and our patients are, they're angry that allopathic medicine does what it does. And I think what we did as we kind of looked at the book, and as we've become a little softer, is realize that allopathic medicine has a place at diagnosing disease and managing disease as it progresses. And really, that's where they're really good at acute care, diagnosis of disease, management of that disease through drugs or surgery. But that's not really healthcare, that's disease management.
Right.
And what we both saw then was, hey, we have a place, they have a place. Now what we need to do is do a better job of helping build that bridge and let people know that, hey, there's both things can live here. And instead of making a book that's more angry and pointing the finger, maybe we need to make it people more aware that your doctors are following guidelines. They're following the rules. It's just the rules are not great for you getting healthy and getting well. The rules are set to wait until you get diagnosed with the disease and then manage the disease. It's not truly healthcare. That's really not the physician's fault. It's really just the way the system is. And I think where we're going to come at physiology from that perspective. We're going to come at functional medicine from a perspective of, hey, both things are beneficial here. Not everybody wants functional medicine. A lot of people need crisis care. A lot of people only want medical management. What we have to offer from a functional medicine perspective is it's another alternative, which is, hey, you need that to keep you safe. But if you really want to get healthy and get well, we got to figure out what's causing your body to operate from this cell stress or cell danger response versus from what we call homeostasis, a low stress state. So that's the perspective we take.
That's amazing. Thank you guys so much. And I'm Kelsey, by the way. I don't know what I guess I'm your sidekick or like your assistant or something. I'm the host of this webinar today for you guys.
You're awesome.
We couldn't have got a better host.
That's right.
And I just want to say, I can speak from experience as well. I have Hashimoto's. I'm actually one of Dr. Eric's patients, and I have read the book also. And it's just so different. I mean, on my bookshelf, there's literally like every thyroid book imaginable out there. And I can say that this one is just so different from all the other ones because it really answers the question of why. Like, why am I still struggling with these symptoms when I'm being treated maybe even by another functional medicine doctor? I've been to so many different doctors, and I still was playing that game of titrating my medication and having to go up and down and being like switching from medication to medication. And I think this book will really help people go, oh, that's why I keep having symptoms, even though, you know, my numbers look good, or I've like switched to the right medication, or I'm doing all the right things. So I'm really excited for this book to come out. I think it's going to help a lot of people. And yeah, I'm excited for you guys to get your word out there for sure. So
and I think one of the reasons, you know, it's, even though this is a book about thyroid to some degree, about thyroid physiology, it's really a book about health and cellular health, and just a different way of thinking. And some of the questions I'm sure today that we're going to answer are the same thing. When somebody says, hey, my T3 is low, do I just give T3? We want to change that conversation from oh, that's low, let me just give this, to T3 is low, but why is it low? We need to understand the why. When we understand the why, then we don't have to necessarily give you T3. We can fix the why it was low to begin with. And the other part of the conversation, and we talk about it quite about in the book, is that when somebody doesn't feel well, we're always kind of assuming that the body's broken. And really what we take a look at from the perspective of health and people having chronic health care issues is their body's really adapting to threats, adapting to stress. It's not that it broke, at least not early on. At some point when you've chronic adaptation, systems can really start to break down. But the early part of not feeling well often is the signs and symptoms of the adaptive changes. Kind of like when you get a virus, you get a fever, you get chills, you don't feel good, you know, but all those things is the immune system kicking into gear to kill the virus, right? Those symptoms aren't the problem. That's actually the body's solution. You know, we all grew up in the model where if you have a headache or a fever, you take something to suppress it. And our grandparents grew up in a model where if you got a fever, that's great. Right. You know, it's going to kill the virus. You'll be better tomorrow. So we want to go back to that. I don't want to say old idea of thinking, like it's old and outdated, but really bring back that idea of we got to address the why. Don't ignore what the body's telling us, instead of try and work with the body versus against it.
Awesome. Love it. All right. Well, shall we jump into questions here? We've got a few people joining us, and I'm sure they do have questions for you guys. So here's how we can do this for everyone attending. If you want to ask a question verbally, you can raise your hand. There's like a little option to do that. It should be on like the lower end of your panel here. And I can unmute you and you can go ahead and ask your question and add as much context as you need. If you want to just go ahead and type your question into the Q&A, that's great too. So if you like don't have the ability to chat with us right now, you can go to the Q&A option below and you can type a question in there, and then I can just read it out for you. So either way works for us, however you want to go ahead and ask your questions. And then, like I said, I have a bunch that people submitted that couldn't join us live, so we can jump into those as well. But if anyone joining right now has a question, either raise your hand and I can see that and I can allow you to talk, or type it in the Q&A to the right there. And if we have to wait a little bit, I can throw in one that we already have. Or you can put it in the chat if that's easier too. Whatever works. So let's start with one that I got in advance. Okay, so this first one is from Larissa, and this one is about iron deficiency anemia. So she wants to know, can you please talk about how to address it? And also, what do you consider an optimal level for ferritin? I've heard some practitioners say it should be as low as possible, and others say it should be around 70, and that low ferritin can be associated with hair loss or thinning. So how do we raise ferritin if that is needed? Lots of questions in there. Dr. Eric, do you want to take this one, or Dr. Kelly? Dr.
Yeah.
Okay.
You want me to go, Cal?
Yeah.
All right. So I think the first thing we got to determine is low ferritin is not a sign of anemia on its own. So a lot of people are told if you have low ferritin, you have iron deficiency. That's not the case. Ferritin is a tissue storage protein. It's not a technical blood protein. So it should not be in the high in the bloodstream. An elevation of ferritin in the bloodstream is indicative of inflammation or oxidative stress or tissue damage. So I know what everybody was told. Optimal ferritin is a sign, high ferritin is a sign of good iron storage. We were taught in functional medicine it should be closer to 90. So 80 to 100 was you want to be right in that sweet spot. And, you know, that's not true at all. The iron researchers in the world say that it should be as low as possible. And I usually looked for it in optimal health to be under 25. So higher ferritin, not a good thing. You don't want to necessarily be raising it. Matter of fact, we learned a lot about ferritin during COVID. I'm not sure if anybody's heard of COVID, but it's this kind of viral thing that's been going on. And one of the things that happened in COVID, if you look at your lab report for women, it'll say that ferritin levels should be 15 to 150. And I think for men, it should be 15 to 300. Anytime you see a range that's that wide, that means nobody knows what the heck to do with it. So that's A. B, they found that in females specifically, that ferritin over 100 was a sign of COVID infection. So that being said, why would we ever want ferritin to be higher? Okay, so you don't want high ferritin, you want it as low as possible. The next piece of that then is, well, how do I know if I'm anemic or not? And so then we have to look at the rest of the red blood cell indices. We want to look at serum iron. We want to look at total iron binding capacity. We want to look at unbound iron binding capacity. We want to look at iron saturation. And we want to look at the RBCs, hemoglobin, hematocrit, and the rest of the differential. There's two common iron deficiency patterns that we're going to see on a blood chemistry panel. One of those is iron deficiency anemia, which means I don't have enough iron. The other is what we call anemia of inflammation. When you have chronic inflammation, when you have chronic infections, that triggers a danger response in the cells and tissues. And what happens is the body starts sequestering and pushing iron out of the bloodstream into the storage vesicles to hide it from the threat, because organisms, bacteria, viruses, love iron as a fuel source. So the body's pretty smart. It says, hey, the way to kill off a virus or starve off a virus is not allow it to have iron. We learned again during COVID, what was the virus going after? It was going after the iron in the hemoglobin of people. So if you have what looks like, and your doctor tells you have anemia because your iron's low, your iron saturation's low, and your ferritin's low, before you start taking iron, there's one test that you can run that's going to differentiate whether you need iron or you don't need iron. And that's something called a soluble transferrin receptor test. If that soluble transferrin receptor test is normal or low, you do not have an iron deficiency. If it's elevated, you do. So I probably should explain what that is. I'm a cell. If I need iron, I'm going to put up a bunch of these little receptors, these kind of catch things on the outside of my cell, so I can catch all the cell that's coming, all the iron that's coming by, and bring it into the cell. But if I'm a cell that's got plenty of iron and I don't want more, I'm not going to have many of those receptors out there because I don't want to bring more iron into the cell. So if we run a soluble transferrin receptor, it's normal or low. Even if that person looks like they have anemia, they do not need iron. The iron is being hidden, it's being sequestered because they probably have an infection. Okay, so most people, don't try and drive your ferritin levels up by jamming a whole bunch of iron into the system. The body typically absorbs about 1 milligram of iron per day and excretes about 1 milligram of iron per day. It doesn't have a really great system for getting rid of iron. And so don't load it up based on a ferritin level. Now, if you are truly iron deficient, and I just got one of these results back today on the soluble transferrin receptor, it was high, person looks anemic, everything else. The next question we have to ask is this a person who's not eating iron-rich foods? Like, why are they iron deficient? Are they not eating iron-rich foods? Do they not have acids to absorb the iron? Or do they have a bleed going on? Do they have like a gastric bleed? Do they have really super, super heavy menstrual flow? Or do they have like maybe a fibroid that's causing them to suck up all the blood? There is a reason why the iron is low. in the short run, it may be okay to give some iron, but in the long run, we have to start to consider what happened to the iron in the first place. So don't use ferritin on its own. You can't even use just that iron panel on its own to just say that's it. The differentiator, the two most common causes of iron deficiency look, the iron deficiency look on a panel is going to be iron deficiency anemia. True. And I don't think it's very common. I'll let Kelly answer that piece too. But the more common issue for most people is anemia of chronic inflammation. And that is a situation where you do not want to give more iron.
Dr. Eric, really quick, before Kelly jumps in, Larissa asks, is that test the same as the transferrin saturation?
No, that's something different. So the transferrin saturation, or the iron saturation, the iron is transported in the bloodstream on this kind of bus we'll call like transferrin. So it's like a bus, and the body likes to keep it about a third full. So when we look at the percent saturation, what we're looking at is how many of those transferrin molecules, those buses that transport iron around the body, how many of those seats are full. So we want it around 30, 33, 35%, somewhere around that, not more than that. So that's what that's measuring. Okay. Now, it's important. The reason that becomes really important, and it's important in a lot of discussions that we talk about in the book and everything else, is because iron is like a teenage boy. If you leave iron unchaperoned, it will get itself in trouble. Okay. Because iron reacts with everything like a teenage boy. It's like, whoa, 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 what's going on? Right. So iron is always chaperoned from the time it comes into the body until the time it's used. It's always under some type of chaperone. So we don't want a lot of free iron floating around. Organisms like it, reacts with oxygen, creates a lot of stress. Think about it. It's always got to be chaperoned. Cal, you want to jump in there with some nuggets of gold?
I was just thinking of the Fenton reaction too, like the unbound, if we've ever heard of the Fenton reaction, it's the unbound iron, colliding in with other free radicals and causing just massive damage. And so you're right. It is just like my teenage son.
Got it.
Oh, I love it. Awesome. Thanks, Larissa, for that. Both of those questions, actually. All right. Let's grab another one. So this one, you might like to get on the soapbox for this one too, Dr. Eric, and I'm sure Kelly will have stuff to say about this. So this one's from Asha, cool name. I have Hashimoto's and I've made many changes to my diet and lifestyle. However, I cannot tolerate any supplements. I've tried so many and was looking to sign up with a functional medicine doctor, but it seems that they're also reliant on the use of multiple supplements to obtain health. Is this essential for healing to occur?
The quick and dirty is absolutely not. The supplements are not essential. I think it's an interesting term that I heard Dr. Eric use, and it's called the greenwashing of medicine. Instead of, here's your statin, it's here's your red yeast rice, and it's basically the same model. It's just using herbs and things. So my thoughts on that is that I do know a lot of practitioners who greenwash, and yet they feel like they're really doing the patient a service when they're putting them on all these supplements for things. They're doing micronutrient testing and all these things. And yes, I like micronutrient testing, and I think that minerals and vitamins are important. I think that first and foremost, a good diet is important, but of course we have to address magnesium deficiencies and choline deficiencies. But Eric and I, we completely are on the same page. It's that your thyroid function and the hypothyroidism you may be experiencing it's not a lack of some magic pill, some magic supplement. That is not how I regain my health. So I was, and everyone asked me that too, like, Kelly, what did you do to get better, 110% better? What pill did you take, right? There is no one pill. Now, some people will become allergic too. They'll become sensitive to the various types of capsules because they're swallowing 25 pills a day. And so you do get to a point where your body is just not tolerating that anymore, and the fillers in there and things. But I think that's what our book is about, you guys. Our book is about stop these protocols. Stop this this charade of thinking that this bottle here, it says it's going to treat my, my hypothyroid. It's just, maybe in about 10% of people, maybe that'll work. But Eric and I sure don't, those people don't show up at our door. And so, we want to breathe this fresh air, and we want to make sure everybody understands that's not what we're about. We're not about putting you on iodine. We're not about putting you on tyrosine, all these things. We're about asking why. And the answer to the why, 99.9999% of the time, is not a deficiency of some supplement, right? I mean, Eric, you're on the same page with me. And that's what we wrote part 3 about. Part 3 is the roadmap. And maybe we list maybe 2 or 3 nutrients in there that we think are important. Again, like make sure your magnesium's good, make sure like you're, getting a whole foods diet. But part 3 is about the roadmap of how to start addressing what put all this allostatic load onto your body. That's what Eric and I talk about, is like what's adding to the load of the cellular stress that's making your body, making your mitochondria go from the powerhouse to the battleship. Again, you're in this like battleship mentality because your body thinks that it's being attacked, and it sure might, you might have Lyme, you might have mold. There's a lot of different causes, but your cellular stress, your mitochondria is shifting gears, and you're in a cell danger response, is something that a term that we use a lot by Dr. Navio. And it's where your body is purposely going into that battleship response. And the way out of that is not to supplement with CoQ10 and ribose and things. It's to go, what got us there, and then take off the load. So Eric, I'll let you add your.
Yeah, I think supplements can be a huge benefit, right? Because they can make longer processes a little bit shorter, because sometimes we can say, hey, we got to modify your diet, we got to do these things, and sometimes just trying to get things addressed just through diet and lifestyle just takes longer, and people don't have the bandwidth maybe to commit to a long-term strategy, because what a lot of times people fail to realize is they didn't get into this situation the day they got diagnosed, right? This is a 5, 10, 15, 20-year process that developed over time. And really what everybody wants is to get it fixed in a very short period of time, weeks to months, right? Like, hey, what am I going to take so tomorrow I feel better? Probably nothing. I mean, that's the honest answer. So it's going to take time, but we can use supplementation to kind of get to help speed that process up. The problem where we get in trouble with supplements is when we look at supplements from a standpoint of this is low, I'm going to fill it up, right? And so we said, that's high, I'm going to give this, that'll fix it. Because as Kelly said, if there's something low, we have to ask, why is it low? What would cause that to be low? And before we got on this little thing, Kelly and I got into a little discussion about vitamin D. Like, everybody's being told that they're vitamin D deficient, whether you get sun exposure, you don't get sun exposure. If you're taking vitamin D, not taking vitamin D, everybody seems to be low in vitamin D. When everybody is low in vitamin D, the solution probably isn't more vitamin D. The answer is we're probably not measuring it appropriately, or we don't understand how vitamin D works appropriately. So I see it all the time. People come in and say, hey, I'm B6 sensitive, I'm this sensitive, I'm that sensitive. No, you're not. You're sensitive to it. You're not allergic to it per se. It's a term we kind of use, but you're not technically allergic to B6 because it's in everything you eat. It's there. Your body needs it. But what we often do is think that if I put B6 into the system, it's going to support the pathways that my physician saw on a test that they did, and it's only going to affect that pathway, and I'm going to feel better. Instead, what we know from the literature, especially Kelly mentioned Dr. Robert Navio, under stress conditions, the body takes proteins and vitamins and minerals and does one thing with them. And on a low stress state, it may use those things for something else. In a low stress state, you may drive B6 and help support serotonin production, so you feel good and you sleep good and everything, life is good. But in stressful situations, you may use that B6 to drive more inflammatory responses that may not make you feel good. So somebody says, well, you look like you're B6 deficient, so I'm going to give you B6 and you don't feel good. Well, it's because it's driving the process that's going to support what the cell needs in that moment. If it needs to defend itself with more inflammatory cytokines, it's going to use that to make it. If it's in a low stress state, then it's probably going to make you feel better. And I think that's where people get into problems, is they keep adding it more and more sensitives, trying to drive one response, but the cells are in danger and they're driving another response. I think that's a big one. And the other one is that you wind up taking a vitamin of some sort, and everybody assumes that B6 is just B6, but almost every micronutrient that's made is attached to something, right? And the thing it's attached to, you may or may not do well with. B12 is a great example of that. Some people don't do well with cyanocobalamin. Some people do okay. Some people don't do well with methylcobalamin. They really don't feel well with it. And for others, they're okay. For other people, they do better on hydroxy B12, and some other people do better on adenosine B12, right? Because it's based on what the cell and tissues need at the moment. So that could be a factor. And then the other factor is what Kelly said, is not all nutrients are made the same. I mean, there's not a really great standard set to making vitamins. And Kelly's been doing this for years as a formulator, is making it. So she knows firsthand that you can get B6 made really cheaply and really kind of really toxic forms of B6, or you can get it made really well. And oftentimes, unfortunately, the better, the purer the product, the more expensive it is. So as a default, most of us do what we, buy with our pocketbook, not with the science behind us of what's good. And we just say, hey, that's B6, that's B6. It's all the same, not knowing that it probably isn't. Buy the cheaper version, which maybe be more toxic, may have more binders and additives to it, and maybe not make you feel so good. Did we answer the question, Kelsey? I'm not even sure if I got off track.
I think you did, yeah. Basically, the question was, do you need supplements for healing? And the short answer is no. And there's a lot of nuances there. I guess one question I do have is, are there any supplements that most people should be on?
I was gonna say, maybe we should mention like the top things that we actually use, and it's a commonplace. You want to go ahead, Eric?
You know what? I think the thing we see, I think I see most often and I'm most concerned about is magnesium as a deficiency. And even that, I still ask the question, where is it? Why is it so deficient? I think there's an argument to be made that the way we farm, our crops are not as nutrient dense, and that's a big one that often gets depleted from the soil pretty easily, pretty quickly. We have a tendency to excrete it really quickly under high levels of stress, and you need it for about, at one point we thought that you need magnesium for 300 chemistry reactions in the cell. Now we're thinking it's 600 to 800 chemistry reactions in the cell. So I think that's a biggie. The problem with it is we don't know we can't measure it well, right? So we don't have a really great way to measure it unless we want to go get a biopsy done. So we have tools, but I would say that's one of the more common ones. But at the end of the day, what do I think most people need to take on a regular basis? I think most people need to eat real food. They need to digest real food and assimilate that real food. And if they're eating more real food, they're going to get more of those micronutrients. I would say I would favor a digestive enzyme over individual micronutrients any day, because the digestive enzymes are going to be the things that are going to help you break down your fats. A lot of people, Kelly and I run tests, and a lot of people have problems with pancreatic enzyme output for various reasons. So for the general person, it's, a pancreatic enzyme is probably a good, well-balanced place to start, and that's going to help you absorb more nutrients from your food. We could talk about stomach acid, how important that is. We could talk about bile acids, which Kelly and I both geek out over. But, if you ask me, what do I take? A multivitamin, which individual micronutrient? I think I would default to, probably to a digestive enzyme, I should say, and maybe some magnesium as a root.
Yeah, that's pretty much, I was thinking about, well, what supplements do I think that are appropriate after looking at testing? And I think we should kind of back up and say that this is educational information and that no information is meant to be medical advice specifically to you. You know, take this information as education and bring it to your practitioner, you know, and educate them too as well. So, and I think when you read the book too, you will be smarter than your average doctor. But yes, I think that digestive enzymes have been a mainstay. Fiber, you know, sun fiber, your all kinds of different fibers have been really important because people just aren't eating enough fiber in their diet. And then, yeah, the mainstays like of magnesium and but I'm not a fan again of like mega dosing vitamin D or mega dose. There's just it's just sloppy. So you know, if someone wants to put you on mega doses of anything, it's okay to question that.
Awesome. That was a great answer. I love it. Okay, let's go with another question. Dr. Eric mentioned infection in relation to iron. What are your thoughts about root canals and their impact on health? It seems that my root canal did not completely eliminate infection, and I'm wondering about how that might be contributing to my symptoms. Root canals?
Yeah.
Well, yeah. You want to go, Cal?
Yeah. So I train under Dr. Jerry Tennant, and you know he has a whole entire course series on root canals and silent infections and how they can harbor. He would say that 100% of root canals are still infected. I don't have any data to support that 100%, but I would say that it's something that when someone cannot get over the hump with their symptoms, it's something that we start taking a look at. And I partner with a dentist, a holistic dentist, and you know he does a 3-beam cone scan where he can actually see if there's still residual infection. So I will defer out to my friendly holistic dentist to make sure, and they'll usually have to, and actually this happened to me. I had to have the tooth extracted. I had to have ozone in there. I also had to have some stem cells put in there. But guess what? I felt a million times better after I got that. It really was like, oh wow, and I feel another level better. So I truly believe that if you're still having health problems, it is definitely worth a holistic dental consult.
Yeah, absolutely. Listen, I've got a dozen clients right now that have antibodies to oral bacteria, P. gingivalis, strep mutans, or both. And so for the person who's listening, P. gingivalis is a common bacteria in the oral cavity. Strep mutans is another bacteria in the oral cavity, and that's where they should stay. And what happens is you get infections in the mouth, and then these bacteria can either, if you got receded gums, they can get down there and they can get into the body, or their toxins can get into the body. Same with when you have a root canal, you get infection in there, and that can continue to trigger immune and autoimmune conditions. And you would think, well, wouldn't I have pain? And half of those clients that we had positive antibodies in had no oral symptoms at all. It was picked up because they went back and got the cone beam x-ray done and their dentist found it. And one of my clients, I think she's got three teeth that are rotting, you know, that had work done in them. There's real bad infection. She's losing bone mass, really bad infection. I mean, and she'd been to a bunch of functional medicine practitioners before she came to me, and, you know, never had any success out over 20 years. And it's probably because she had root canals done 30 years ago and they never healed. They just got worse. And that was probably the root of her issue. And it created multiple autoimmune conditions, which everybody tried to treat, suppress the immune system. And really suppressing the immune system, what did that do? That allowed those infections probably to get worse with time, not better. The immune response wasn't the problem. The immune response was the indicator that, hey, there's still something going on. So yeah, and there's ways to check, right? The x-ray is one way to check. I just happened to run Cyrex's Array 12, which has 2 oral bacteria that they have on there that they test for. Mm-hmm. And so far in the last, let's say 4 months, I know I have 12 active patients that we have them back at their dentist getting it checked. Interestingly, one of those people went to their general dentist, and the general dentist said, hey, there's nothing wrong with your teeth. It's fine. You don't have any infection. She went to a second dentist who did the cone beam and said, oh, no, you got a really bad infection. And that made way more sense for what her symptomatology and everything was. So it absolutely without a doubt.
For the person who asked this question, can you repeat the name of that test? I've never heard of it. Cone beam?
It's an X-ray. So it's a way they image. It's a special type of X-ray, right, Cal?
Yeah, exactly. And there's, I would say too, there's a meridian tooth chart that's a little bit interesting to see if your symptom patterns match up. Every single tooth is linked to an organ system, which I find just kind of interesting to check out.
Okay, meridian tooth chart and cone beam X-ray. Hopefully that'll give them somewhere to start. Awesome. All right, we got another question here. Also ferritin. I'm actually curious your answer to this one. So Diane asked if your ferritin is really high and your serum iron is low, would you recommend staying away from using a cast iron pan cooking?
No.
No.
Here's why. Because if you have your ferritin is high because you have inflammation or oxidative stress, right? Your iron is low because your body's sequestering it. But the body, the GI tract really only absorbs 1 milligram of iron per day and it excretes 1 milligram of iron per day. So you're not going to get a ton of iron coming from that pan that's going to be excessive, that your body's just not going to bring it across the membrane anyway. We don't need to get into the intestinal transport of that, but it's not going to do it. I mean, you have a ton of iron in your food every day and you only absorb a little bit. So the body really manages pretty tightly the iron absorption across the barrier. And so you could say, well, what about if I have high iron? Isn't that mean I have too much iron crossing the barrier? And what Kelly and I think would both agree on, if you have high serum iron, it could be a condition like hemochromatosis where you've got some genetic issues. But what we see probably a lot is that people have copper deficiencies, zinc deficiencies, vitamin A deficiencies, ceruloplasmin deficiencies that doesn't allow them to do as good a job of offloading the iron to the cells, to the tissues. And that might be a bigger reason why you have higher iron versus, hey, I'm just absorbing way too much. But there, somebody who's looking at, if you have high ferritin and you have high iron, could you have hemochromatosis and have a genetic predisposition? You could, but I would say it's probably not the case if their serum iron's low. Cal, you want to agree?
Mm-hmm.
Perfect. All right. Question from Maha here, or Maja, also a cool name. Sorry if I said that wrong. What is the connection of anti-mitochondrial antibodies and thyroid? Anti-mitochondrial and antibodies.
Kelly, you want me to take that? So the issue is, if you have anti-mitochondrial antibodies, I think what we're looking at is we've got some issues as far as tissue damage, and those are things that could trigger immune, autoimmune type conditions. So mitochondria are these engines inside your cells, and we typically don't have mitochondrial components outside the cell as a regular piece. And so if you have these mitochondrial antibodies outside the cell, that often indicates that we've got cell damage, cell injury, and whether that's thyroid or even if it's peripheral cell, it could be an indication of increased oxidative stress, and it could be an indication of immune driven damage. So I'd say that's a good simple answer.
Okay, great. All right, we've got another one here from Constance. It's a little bit long, so I'm just going to read it to you. So can a low-grade viral infection lead to thyroid issues? I've had a low white blood cell count for years, along with thyroid issues and chronic fatigue. I've taken T4 for years with no symptom relief, and now a new functional medicine doc is recommending T3, T4 combo. My T3 is low, and I have apolipoprotein B antibodies. Any guidance as far as a new path to try? So I guess disclaimer, not giving out personal medical advice here, Constance, but maybe we can give you some some guidance as like a new test to do, or some kind of other direction there.
So this is our bread and butter, right, Eric? I mean, this is what we see pretty much every day. So I will comment first is that your white blood cell count, a lot of studies have shown that that is the single marker that shows your overall health. And so when it's low, it's ominous. There's something going on. And I would say this is that I have seen people just following what we describe in part 3, the whole health plan. I've just seen them follow these gut, simple foundation things, and their white blood cell count just tracks right on up. And that's my marker for what we're doing is really working, because that white blood cell count's coming up. So I'll say this is that, yes, it's very significant that it's low. Yes, you could have some chronic viral infections, and that could be triggering the cell danger response. And then that can be causing the hypothyroidism. Again, I think I'm going to let Eric go into that physiology a little bit, but it's all related. It's all related. That's what I love about in not, being in that allopathic box, is that we, cardiologists here and neurologists here and GI there. I mean, this is one system here. And so, looking at it from that approach, there's definitely some things I think that your body is probably really under that viral. I would love to hear if you've had viral testing, if you actually know, or if you just think you have chronic viruses. But definitely your symptom pattern is a person stuck in that cell danger response. And so appropriately, any amount of thyroid hormone at this point, that's not the problem, right? That's not your issue. So Eric, take it away.
Yeah. Well, obviously we know that latent infections, viral, bacterial, or any organism can trigger chronic cell stress, chronic inflammation, cell danger response. And part of the cell danger response is for a cell to not convert T4 to T3. So I talk about this all the time. Kelly and I talk about in the book, cells operate either from a low stress mode, they're in manufacturing mode, they want a high T3 to drive the manufacturing process and turn off the immune inflammatory response. If they're sensing danger, they want to decrease the amount of T3 in the cell, turn off the manufacturing process, turn off the energy production in the mitochondria, kind of turn it down and ramp up the immune inflammatory processes to protect itself. So it's not unusual that you would have hypothyroid symptoms if you have a chronic infection, because the body's reducing mitochondrial function. You're reducing the T3 binding to receptors that make proteins and enzymes and ATP and energy. And instead, you're getting activation of inflammatory mechanisms. So for sure, we look at chronic hypothyroid symptoms, regardless of what your TSH is, as an indication that there's some type of cell stress going on. So not hard to believe any organism could potentially do that. Low white blood cell count, there's a lot of reasons you can have a low white blood cell count, but one of the most common ones is a chronic low-grade infections for sure. I mean, there could be folate deficiencies, it could be copper deficiencies, but as we said at this outset, why would they be low to begin with, right? So that would be another question we'd ask. And we'd also see other patterns for that. Maybe in the iron panel, we'd see patterns of looking at a CBC and differential. We'd be able to take a look at, are there other markers of folate deficiency? So, but typically when I see a low white blood cell count, I'm thinking, we got some type of chronic immune response going on, probably chronic infection. I've taken T4 for years and no relief in symptoms. Well, it doesn't matter. So when we look at thyroid physiology, your allopathic physician's usually looking at it from the thyroid gland down. Like the whole problem is the thyroid gland mysteriously just shut down function, and everything else downstream, transporting the thyroid hormone in the bloodstream, transporting the thyroid hormone into the cell, the conversion of T4 to T3, and T3 binding to receptors. The medical doctor's assuming that all of that works really well, and it's just this mysterious destruction of the thyroid gland. You just woke up one day and it doesn't work anymore. It's the way life goes, right? Or you had somebody radiate it out or cut it out. We want you to look at it differently. And this is a huge part about what we're talking about in the book. Most people start to have hypothyroid signs and symptoms long before they get diagnosed with the thyroid problem, long before their TSH even moves. If you didn't know this already, by the time your TSH is above lab reference range and your free T4 drops below the reference range and your diagnosis is overt primary hypothyroidism, you've lost more than 90% of the function of your thyroid gland. That's in the literature. That's in the research. That's not the beginning of a thyroid problem. That's the end of a thyroid problem. Okay. So how could you have hypothyroid signs and symptoms before that? Because two things regulate thyroid hormone. What we call the hypothalamus pituitary axis regulates how much the thyroid gland is producing. And then you have the peripheral tissues away from that area, like your liver, like your pancreas, like your muscles, that all the cells and all the tissues get to self-regulate for the most part, how upregulated their metabolism is or downregulated their metabolism is. So if I'm a liver and I'm perceiving excessive stress, I can slow down the metabolism of the liver, but your GI tract can work fine, or your hypothalamus or your brain or another tissue can work fine. So every tissue has the ability to self-regulate its metabolism. But what we see is that when somebody has an infection in their gut, it's going to change your thyroid physiology in the start, definitely from the gut perspective, and eventually it's going to start to impact other tissues. So for sure, part of the reason why you take T4 and you don't see change is that your thyroid gland destruction probably wasn't the beginning of the problem. You have this cell stress response going on in the tissues, and your cells didn't want to convert T4 to T3 in the first place. And so you started getting more T4 to reverse T3 conversion, less T3 conversion. You started to feeling hypothyroid. The chronic stress response probably occurred for a longer and longer period of time. And eventually that resulted in thyroiditis or inflammation of your thyroid gland that results in the primary hypothyroidism. So this is one of those things that's like on a classic, like this person has tissue issues going on. When they take T4, they normalize TSH and they still don't feel good. Something's going on in your peripheral cells. You have the cell danger response going on, and that's why you don't feel good. Now, what do you do about it? Right? Well, one of the things that physicians will do is they'll keep giving you higher and higher doses of T4 and they'll keep driving your TSH lower, thinking if they can just drive that T4 high enough, the cells will get what they need. And the problem with that is TSH drives an enzyme called deiodinase 2. So when you suppress TSH, you have less deiodinase 2 activation, and that's the enzyme in your thyroid and in your cells that converts T4 to T3 inside the cells. Most of the T3 in the body isn't made by the thyroid gland, it's made by the tissues in the body. So if you suppress TSH too low, you're going to feel more hypothyroid. Now, there is a break point when you really exceed the amount of T4 the body needs. Then you have another enzyme called deiodinase 1 that'll kick in and try and help convert T4 to T3, and it will make your T3 look better, but you'll still be hypothyroid because that's not being made inside the cells. That deiodinase 1 is being made on the periphery of the cell, and it doesn't support the cell on the inside. So why would the body do that? Well, the half-life of T4 is 7 days, so we don't want T4 hanging around that long if we're overloaded. The half-life of T3 is 12 hours. So if we can convert T4 to T3 and then half-life is 12 hours, we can get rid of it much faster. So we kind of mitigate that hyperthyroid state a little bit faster. The other thing that happens is, and this is where I give functional and integrative medicine a hard time, is because a lot of people say, well, you're just a non-converter. You can't convert T4 to T3. Your free T3 is low. We're going to give you free T3 and it'll work better. Well, the blood might look better, but that doesn't mean what's going on in the cells and tissues is going to be better. You may get that honeymoon phase where you feel a little bit better. And then what I've seen happen is you need a stronger dose. You need a stronger dose, because what people fail to realize is that if there was enzymes in those cells under stress that were converting T4 to reverse T3 instead of T3, that same enzyme, deiodinase 3, converts T3 to T2, and some of the T2 supports mitochondria. The rest of the T2 does not work. It's like an inactive form. So you still got the same issues going. You haven't fixed the problem. You've greenwashed the whole thing because you've said, hey, look, the numbers look pretty, and yet you don't feel good. So I think my T3 is low. I got that one. The other part of that was, why is my apolipoprotein B I have apolipoprotein B antibodies. Look, anytime you have reduced liver T3, reduced T3, T3 regulates all the enzymes that regulate lipid metabolism. Okay, so if you have reduced T3, especially at the liver, the enzymes that are supposed to be lipolipase, am I saying that right? LPL, right? All the HPL, all these enzymes that regulate lipids are really T3 driven enzymes. So you need T3 for all those to work, which is why cholesterol levels go up. You need T3 in the liver for the LDL receptor to work, so you can dock cholesterol at the liver and pull it in so you can make bile acids. And if that's not happening and you've got all this cholesterol and you're getting cholesterol oxidized, that ApoB is part of all those molecules. And so, yeah, you're going to have debris, and that debris may result in more antibodies against that protein. Did I get everything there?
Oh yeah, that was great.
Sorry.
A lot of what you covered in there is kind of like the crux of your guys' book too. So if that was an interesting rabbit hole for you guys, like definitely check out the book, because a lot of that, when I read in the book, I was like, oh my gosh, this is exactly what I've been going through. So that was awesome. We only have about 1 minute left. There is one more question in the Q&A. I wonder if we could do like a lightning answer to it, because I think this is something you guys see a lot. So this person has taken Levoxyl for years, but has all the hypothyroid symptoms. They recently changed to Armor. How do they know if adding T3 was the right decision? Is there a test to show how they're doing on it? They don't feel any improvement, and they have increased hair loss as well.
Yeah, I would say it's not working.
How you feel?
Yeah, I would say it's not working. And the other thing to do, an astute functional medicine practitioner should be able to look at the tissue indicators of thyroid physiology. Are they less insulin resistant? Did their insulin levels go down? Did their fasting glucose go down? Did their lipids improve? If the tissue indicators of thyroid hormone haven't improved, then they're not doing better.
Totally.
Okay, so it probably wasn't the right solution, but their blood levels may look better, but that doesn't always correlate with better health.
Mm-hmm. For sure. Okay, awesome. Well, we are at the end of time. Thank you guys so much for joining and for all of your questions, and Dr. Kelly and Dr. Eric for all of your amazing answers. We had a bunch that we didn't even get through. So hopefully you guys can join us for the next one. I believe it's exactly a month from now. So stay tuned in your emails. We'll send out invites for those. We'll send out more book updates, all that good stuff. And then if you haven't yet, you can connect with Dr. Eric on social media, on Instagram. Dr. Kelly's website is on our book website as well, and her Instagram too. So yeah, that was awesome. Do you guys have anything that you want to end with?
I would say, hey, we thank you for coming and listening to this and to giving us the questions, which is awesome. As Kelly and Kelsey both know, I could talk for hours on stuff like this because it just gets my juices going. But what I think would be helpful for us, if this was helpful and you're on social media, share what you thought of this on social media and say, hey, this was a great Q&A. It's help other people find our next Q&A and share the content, because really at the end of the day, we're trying to help more people get healthy and get well.
Absolutely.
Good.
Dr. Kelly, anything to add?
No, I think Eric said it all. I'm happy to be here and excited to do it again.
Awesome. All right. Well, thank you guys so much for joining. Everyone have an awesome day. And we will send out a link to these webinars as well if you want to review anything that they covered. So, all right. We'll see you guys at the next one.
Thanks, everybody. Bye-bye.
Bye.
Bye.